All right, we're going to move next to Dr. Andrew Eller, presenting on ophthalmologic considerations in patients with familial aortopathies. Dr. Eller is a professor of ophthalmology here at the University of Pittsburgh School of Medicine.
Thank you. Good afternoon. So, going from the heart to the eye, it's not too far apart. I don't think I've ever said or read the word aortopathy until I was invited to give this talk. And so this is as interesting for me as it is for you, hopefully. So you know about aortopathies, and you also now know that they can affect extracardiac vasculature in similar tissues with same embryologic origin, such as the cornea, the lens, the iris, sclera, and the retina. And Marfan is a syndrome that I'm most familiar with, and the other ones I know very little about, except now I know more about Ehlers-Danlos than I've ever known before, thanks to the previous presentation. So Marfan was actually described by an ophthalmologist, so good for us, right? And what he recognized was ectopia lentis, kyphoscoliosis, and long, slender fingers. I'm sorry I missed the morning session on genetics, but I'm sure it was fascinating. And what we know is that it's a defect in the FBN1 gene in the chromosome 15, which results in defective fibrillin 1, and that leads to a faulty extracellular matrix and the formation of myofibrils. And fibrillin is actually seen throughout the eye, particularly in the cornea, the lens, the zonular fibers, and the sclera, and that leads to the problems that we do see. Ectopia lentis is seen somewhere between 60 and 80% of patients. And so when we see that, and patients do not have a diagnosis of Marfan or aortopathy, it's really incumbent upon us to refer the patients to a cardiologist for a full evaluation. Interestingly, about 19 to 39% of these patients also have strabismus, which means their eyes are not lined up, one eye is turning in or out, and there's probably several reasons. It could be that there's myofibrillin in the muscle or the pulleys affecting the eye muscles, or perhaps because of the ectopia lentis, they get blurred vision in one eye, so one eye develops differently than the other as far as vision goes, and so they get amblyopia. Patients are a very high risk for myopia, and lattice degeneration is a degenerative change in the peripheral retina that is associated with retinal detachment. And they're a very high risk for retinal tears, which can precede retinal detachment, which has been seen in 5 to 26% of patients, depending on the study. And this is bilateral in a very high percentage of patients, 30 to 42%. And this is the most common cause of irreversible blindness, because retinal detachments in these patients can be very tricky to repair. They tend to have very small pupils, so it can be difficult to evaluate the retina, and they tend to have iris defects thought to be due to problems with the iris sphincter muscle, and they can get an acute form of glaucoma, which I'll discuss in a minute. So as far as the cornea goes, it really isn't an issue with the vision. It's just a little flatter, a little thinner. It's more of an issue for us as surgeons when we have to do corneal surgery, because it can be very thin and it can tear very readily. But from a vision standpoint, it's really not that big a deal. But here's a side view of the cornea, and you can see it's like a watch crystal or a dome on the surface of the eye. Ectopia lentis, that's the one that we see most commonly. And if you think of the lens of the eye as I use the term an M&M, and I was going to put an M&M on top of the trampoline. I didn't get around to that. But you can see all the springs around the mat of the trampoline. Those are the fibers, or the lens zonules, that hold the lens in place. So if you can kind of imagine, you've got this M&M held in place by little springs all the way around, or the zonules. And so here's a figure of the zonules themselves. You can see those little wires or strings. And looking at a side view of the eye, here's the lens, the M&M, and the zonules that are suspending it in place, very much like a trampoline. So here we are with ectopia lentis, and you can see how the lens is dislocated, in this case, superiorly, which is most common with Marfan's. Homocystinuria, the lens tends to be displaced inferiorly. Marfan's, I think they're tall, it's up, homocysteine down, and so that's how I think about it. Generally speaking, because they have small pupils, the pupil is going to be centered somewhere over here, so the dislocation of the lens can only affect the eye, the vision, in a sense that it may induce some astigmatism or irregularity in the refraction, but patients with this problem can actually be corrected with glasses or contact lenses to see very, very well. The problem comes in when you try to do cataract surgery, because when we do cataract surgery, we like to make a little round opening. Again, if you think of the lens as an M&M, we like to make a round opening in the center of that thin candy shell. We stick a needle into that chocolate, maybe it's chocolate with a peanut M&M, and we stick that into the needle is ultrasound, so it vibrates and it turns the chocolate into chocolate milk and it sucks it out. And this is why cataract surgeons make so much money, doing these all day long. It's actually the most common surgical procedure in America. I think it's something like 3.5 million cataract surgeries are performed in a year. You only have one heart, we have two eyes, so we can double our income here. The trick is when you try to make this round opening in an eye or a lens that's unstable, it's going to be moving around. That makes it incredibly tricky to do the surgery. And I was going to try to put a video in this to show you, but you can go on iTube. Not YouTube, but iTube, E-Y-E tube. Do you have a heart tube? You should get one, But we have iTubes, and you can look at videos of any eye surgery you want. In fact, you can probably find them on YouTube also. But they have different gadgets. You can put little plastic rings inside the lens capsule to stretch it out. There's rings that are fenestrated, so you can put a suture through it to secure it to the wall of the eye and so on. And then you can do your regular cataract surgery. It's a very elaborate thing. Occasionally, rarely, the lens can actually come forward into the anterior chamber, and that then blocks the drainage passages or channels of the outflow of the aqueous humor, and that can result in an elevated eye pressure. And this is an acute elevation of eye pressure when it occurs suddenly, and that acute glaucoma is very painful. Patients get headaches, they get in addition to the eye pain, they can actually get nauseousness and vomiting. And I've heard of a couple cases of patients having their appendix removed because they're in such pain, forgetting about the eye. So this is a rare complication, but obviously anybody with an acute eye pain needs to be evaluated urgently. The other thing that can happen is the lens can fall backwards. And I've seen this more commonly than the acute glaucoma, and they fall into the vitreous, and you can see the lens sitting in the back of the eye. And I actually have a couple of patients where I've just simply followed them. One of my patients only has one eye, had a detachment in the other eye. The surgery failed, so it's his only seeing eye. And although I could do surgery and remove this lens, it's not bothering him. His vision can be corrected with a contact lens or with glasses. And I watch him every year. The only real risk here is that there are proteins in the lens that are immunologically unknown to the rest of the body. So if the lens capsule were to inadvertently rupture or develop a leak in it, then those proteins could get into the eye and you would get an immunologic reaction which could cause a very hot inflamed eye. So I educate these patients that have this and say, look, if your eye gets sore, painful, red, you need to come in immediately. Then we have no choice but to remove the lens. But that's actually fairly unusual, thank you. Thank God for that. So visual symptoms from ectopia lentis. Blurred vision. They most likely will need optical correction. They can have monocular double vision. Most of the time we think of double vision, we think one eye's looking here, one eye's looking over there, and so you see two images. But if you close one eye and you still have double vision, that's a refractive issue, and typically that would be because the lens is off kilter and it's giving you that monocular diplopia. Astigmatism, obviously, because the eye may be spherical as far as the cornea goes, but the lens is going to induce an irregularity in the vision. And as mentioned, anterior dislocation of the lens, acute pain and vision loss, and the posterior dislocation, it's going to be a sudden loss of vision because there's nothing to focus light on the retina, but it's going to be a painless loss of vision. Then the other thing we see is the sclera is very thin, and it makes sense. If the fibers, the collagen fibers in the eye are weakened, the eye is going to be stretched out. So instead of being more of a round ball, it looks more like an egg shape. We hate operating on these eyes. The sclera is so thin, it can be hard to suture, it can tear, and you can see here the bluish tint of the choroid coming through the eye, and that's simply because it's so thin. But having said that, retinal detachments are more common in patients with aortopathies. In Marfan, it's 5 to 26% of patients, and bilateral 30 to 42%. And we're not really sure of the mechanism. It could simply be because we try to do lens surgery, and cataract surgery is associated with retinal detachment in about 1.5 to 2% of patients. And when they're more complex cataract surgeries, it's a higher rate of detachment. But the way a detachment generally occurs is that the vitreous gel, which fills the inside of the eye, and it's kind of like an egg white, very gooey, as we age, becomes more watery. And when it becomes more watery, it collapses on itself, and it pulls away from the retina. So virtually everyone who lives long enough is going to get floaters, because as that jelly pulls away from the retina, it's going to pull a couple paint flecks off the retina. They float in the eye. You are in a bright light situation, looking at the sky, looking at a white wall, looking at your computer screen, and that light comes in, hits the floater, and that casts a shadow on the retina, and that's what gives floaters. When that occurs fairly acutely, as the jelly separates, it can also tear the retina. And in a small group of patients, that tear then can lead to a retinal detachment, because this watery gel then will seep through the hole under the retina and cause a detachment. If we catch those early, we can generally save the eye. In Marfan's, again, the surgery is a little bit more complex, but I think it's like 80% successful, which is, considering blindness, it's not bad. So the symptoms of retinal detachment: the sudden onset of floaters, or cobwebby floaters, flashing lights. The retina has no pain fibers, but if the jelly pulls on the retina, it's going to depolarize the retinal cells, and that will cause a flash of light. This is different than a migraine type of aura, very, geometric, beautiful lights. It's much more of a very brief lightning flash. It tends to be dim, so you'll see them in dim light. And then when the retina does detach, you will lose that vision. It's a solid scotoma, solid blockage of vision. It's a shadow or a curtain. And depending on the location of the detachment, it could come from any angle in the eye. But eventually, with progression, it would take away all the vision. And then I'll just mention these other syndromes: Loeys-Dietz syndrome, which I believe was mentioned in the presentation from Children's. There's 6 subtypes. Subtype 4 has more ocular signs, and these patients tend to have myopia, astigmatism, blue sclera, ectopia lentis, cataracts, and retinal detachment, and something called fever, which is basically a congenital vascular condition from embryologic problems. And then, of course, Ehlers-Danlos syndrome. And now I've learned that when I see a patient with angioid streaks, which is one of the findings we see in the retina, generally we associate it with pseudoxanthoma elasticum, which can have cardiac conduction defects. Now I know that Ehlers-Danlos syndrome patients need to be referred for cardiac evaluation, and as they are at risk for aortic dissection. And these are some of the ocular manifestations of that. And one of them is a spontaneous carotid cavernous fistula. And what happens in these cases is the blood vessels on the conjunctiva and sclera become arterialized. And so patients will come into the ER with a headache, and some ER docs say, "Oh, you just have conjunctivitis," and they'll give them some antibiotic eye drops. So you have to look a little bit more carefully at these eyes. And then a condition I'd never heard of. Do you guys know about this? Iris flocculus familial thoracic aortic aneurysm and dissection syndrome? Never saw it, huh? I think there's I'm happy I can actually pronounce this condition. Anyway, it's associated with gene ACTA2 and MYH11. I'm sure you're going to be looking for this from now on. And so it's associated with congenital mydriasis, which means a dilated pupil, impaired accommodation, so they don't focus, which is something old people can't do, but young people can in a PDA. And this is what it looks like, these little bumps on the pupil. So when to refer to ophthalmology? If there's a family history. When you diagnose an aortic problem, you should probably send patients to us so we can take a look at their eyes. And anytime they have a new onset of an ocular symptom, such as blurred vision, double vision, loss of vision, flashing lights, and floaters. Thank you.